Professor Catherine Nelson-Piercy is a consultant obstetric physician at Guy's and St Thomas's Foundation Trust and lead obstetric physician for the South East London Maternal Medicine Network. In 2010, she was awarded the title of Professor of Obstetric Medicine at King's College London. Her undergraduate studies were at King's, Cambridge, and St Bart's hospitals. She trained as a physician and was taught obstetric medicine by Professor Michael de Sweet. Professor Nelson-Piercy is past president of the International Society of Obstetric Medicine. She was founding co-editor-in-chief of the journal Obstetric Medicine, The Medicine of Pregnancy. Professor Nelson-Piercy is a member of the NHS England expert group that developed a networked model for maternal medicine and has been involved in the development of several evidence-based national guidelines, notably the RSOG Green Top Guidelines on reducing the risk of thromboembolism during pregnancy, birth, and puerperium, and management of nausea and vomiting of pregnancy and hyperemesis gravidarum. She has over 280 publications, has edited 5 books, and has written the successful Handbook of Obstetric Medicine, now in its 6th edition. She is also one of the central physician assessors for the UK confidential inquiries into maternal deaths. It is my great pleasure to welcome Kathy, our keynote speaker, to share insight into her work in pioneering obstetric medicine in the UK and beyond.
Thank you very much, Ciara, for that introduction, and thank you for inviting me. It's a huge honor to be here. I want to start by embarrassing Ciara, and I want to thank every Trinidadian in this room for giving her to us and for producing such an amazing physician who is going to be such an asset and already is an asset to the obstetric medicine community in the UK and to in London in particular. So Ciara, I know everyone in this room knows you, but they don't know you like I know you, and your work ethic and just getting this day together, it's just tremendous, and I'm very, very proud to know you. So I'm guessing that some of you might actually not know what an obstetric physician is, so I thought I would just put it on a slide to explain. Ciara doesn't yet know this, but as she goes through her consultant career, she will spend most of her time explaining to most of the audiences that she's not an obstetrician. I've been doing this for 30 years, and so we're not obstetricians, we're physicians, which you then have to say, actually, we're internists, because the rest of the world thinks that physician means doctor. So, Ciara, you have to say, I'm an obstetric internist, and then most people will understand what you are. We specialize in the care of women who have either acute or chronic medical problems in pregnancy. We have special expertise in the knowledge of which medications are compatible in pregnancy and in breastfeeding. And we don't take over anyone's patients. We work to coordinate the care of the women that we care for to make sure that they have access to multidisciplinary expert care before they're pregnant, to give them counseling, while they're pregnant, after they're pregnant. And to the midwives in the room, we advocate for normality a lot. And that's because we understand that cesarean section is not necessarily the easy option, and we understand the nuances. We speak obstetric and we speak physician, and so we often just act as translators. So the role is complementary. We work with specialist physicians, not instead of them. We don't replace cardiologists, we don't replace diabetologists, and we don't replace obstetricians. We can't deliver babies. We absolutely don't want to deliver babies, apart from our own. And we work, as I've said, joining these two specialties, not as a hybrid, because we are primarily physicians, and we project manage complicated cases so that women can receive the best care. And that often means joining the dots. I've said about translating. And as has been mentioned already this afternoon, the demographics of our pregnant population now is completely different to when I started my career 30 years ago. Women have multiple comorbidities, they are older, they are more obese, and they enter pregnancy with 2 or 3 comorbidities, as I will show you. They have multiple medications, And there is this fear because of thalidomide, because of the stigma of thalidomide and then valproate and still Bestrol, that every drug in pregnancy is dangerous and the baby is going to be malformed as a result of any drug. That is the default belief of many, many physicians, and that needs to be, we need to work very hard to accumulate more data and to educate the world about the compatibility of medications. Women who are pregnant get the wrong care because people leave stuff out. They don't do chest x-rays. They don't treat them the way they would treat a non-pregnant person. And that means they are very vulnerable. And so we often advocate, and the commonest thing we ask our specialist physician colleagues is, what would you do if this woman wasn't pregnant? What would you do if this was a man? How would you treat this problem? And then we think, well, can they do this? Yes. Can they do that? Yes. Okay, so do what you would normally do, is normally what we end up saying. Most drugs don't have a license or a label for use in pregnancy, and therefore people are worried that if you prescribe that drug or you sanction the use of that medication in pregnancy, that if the baby has a malformation, you're going to get blamed for that. You'll never get blamed for that, even in litigious societies like the United States, provided you document that you've researched it, you've counseled the woman, and that she understands that counseling. And I've never been sued for prescribing a drug in pregnancy. I've never been sued, full stop, in case you're worried I've been sued for something else. Errors of omission are very common, as I've said. Most obstetricians lack medical knowledge. I don't mean general medical knowledge, I mean physicianly knowledge. Most physicians lack any obstetric knowledge. And the more we've specialized and this probably does not yet relate to Trinidad and Tobago, but in the UK, everyone's a specialist very early on. Think of it as a pluripotential stem cell. And we become eosinophils after 3 or 4 years, whereas we used to take 10 years. And that means that you've forgotten your obstetrics by the time you're a medical registrar. Similarly, as an obstetrician, you've forgotten your medicine by the time you're FY1, FY2, and people are becoming de-skilled because they're too specialized. The other thing we do is, we're generalists, which is one of the great things about the specialty. I never wanted to specialize. I just wanted to be a general physician. And in the UK, I couldn't do that. Obstetric medicine allows us to do that because we look after everything. But we also get to look after some really cool conditions that only affect pregnant women. So we look after women with acute fatty liver of pregnancy. We look after interstitial lung disease, which obviously can affect non-pregnant women, but looking after that in pregnancy has nuances, similar to looking after pulmonary hypertension in pregnancy. And remember that women die from acute medical problems, and it's learning how to manage those recognizing them in pregnancy and how to manage them in pregnancy and how not to make those errors of omission. That is basically what our specialty is. So you've seen data for Trinidad and Tobago about maternal mortality. These are the UK data. And you will notice that the leading cause of death first of all, you will notice that the death rate in the UK is half of what it is in Trinidad and Tobago. It's 13 per 100,000 mortalities. But what you might not know is that 3 years ago, that figure was 11. So embarrassingly, in the UK, the maternal mortality rate is increasing. But as Ciara has already pointed out, the major causes of death are medical conditions. Women do die from preeclampsia, they do die from postpartum hemorrhage, but they die in much greater numbers from COVID, obviously during the pandemic, from pulmonary embolism, which is counted as a direct death, but actually it's a medical condition, from respiratory disease, from cardiac disease, from neurological disease. So you're not going to reduce that death rate unless you employ physicians to help you look after pregnant women. So I'm very grateful to Melanie, who you'll hear from later on this afternoon, for this slide, which shows you that women now enter pregnancy in the UK much more likely to have comorbidities and much more likely, they're older, they're more comorbid, as I've said, and they're much more likely to be on medications, multiple medications, at the time that they conceive. These data are also taken from the confidential inquiry, and these are certain characteristics of the women who died between 2019 and 2021. And over half of them have a comorbidity, a medical comorbidity, and that's not just the women who die from medical conditions, it's the women who die from obstetric conditions. If you have a comorbidity, you're more likely to die from either a direct or an indirect death. We've spoken already, and your Honourable Dean has mentioned the fact, and I'm so pleased that I have anaesthetists on this slide. I hope the anaesthetists are on the slide. So the anaesthetists are absolutely integral to the care that we give, and we try and keep women in the centre of our care. And all these different doctors, all these different specialists help contribute to the care. But I made this slide before the advent of maternal medicine networks. And where is the obstetric physician in all of this? That's where the project management comes in. You have to bring together all these different specialties in multidisciplinary team meetings and make sure that everybody is understanding everyone else's point of view and advocating for the women, not just for their own specialty and their own point of view. So, if you're going to reduce maternal mortality and maternal morbidity, leaving things as they are is not good enough. We have joint clinics, so you have joint obstetric and specialist clinics, for example, diabetes in pregnancy. Joint obstetric specialist clinics, they're incredibly important, but they're not enough because they deal with chronic disease, pre-existing disease. They don't deal with all those acute medical problems that women present with to the emergency department. So we need project managers, and that's a big role. And these, as you will heard of, in the UK we have the RCOG and we have these green top guidelines. And one of the areas where this is very important, and again the Dean has mentioned this, is intensive care units. Intensive care units are very scary places. And I'm very lucky to work in a unit which has 3 obstetric intensive care units, and they're very welcoming, and you're never made to feel stupid or inadequate when you go there. But a lot of people think that the woman's in ITU, you don't need to go and review her. On the contrary, she's the sickest woman that you have. You have to review her every day, even if you don't understand what all the beeping machines are, even if you don't know what any of the infusions are, even if you don't really understand what they're doing. There is a role to be played for every specialist in reviewing patients on ITU. And we pride ourselves that our midwives are absolutely fabulous at making sure that the woman has access to the baby and that she has skin to skin, even if she's unconscious. And things like that are really important in providing holistic care. Where can we make a difference? Well, I believe we make a difference in accurate diagnosis, in appropriate and timely investigation, in the management and treatment of medical conditions in pregnancy. And we offer a one-stop shop because we're general physicians. So in the UK, some women have to go see a cardiologist, a neurologist, their obstetrician, their midwife, 4 different clinics, sometimes in 2 different hospitals. That is not woman-centered care. Obstetric medicine can sort out most of those problems in a one-stop shop with the obstetrician, with what we call a high-risk midwifery team, where the focus is on providing continuity of care for that woman, but by midwives who, you'll hear from Sharon later, and I'm sure she'll explain how that works. Now, I'm going to teach you a little bit of obstetric medicine. Forgive me, but it's really important. So the first problem we have is knowing what's normal. You cannot assess a pregnant woman with a medical problem if you don't understand what's normal. And a lot of what we do is just reassure the medical registrar that an alkaline phosphatase of 1,000 does not worry us. It's just the placenta making alkaline phosphatase. It's okay in that direction, but what about if the creatinine's 90 and the medical registrar ignores it because they think that's normal? So all of these normal ranges change in pregnancy, and to be able to work out if something's wrong, you need to know what's normal. This is not an exhaustive list, it's just an example. And ESR is a good one. A normal erythrocyte sedimentation rate will go up to 40 in the first or second trimester. It may go as high as 60 in the third trimester. You cannot use the ESR to work out if somebody's vasculitis is active unless you know what her baseline ESR is in early pregnancy. This is a really good study performed from the group in Oxford who did something very, very simple. They took lots of pregnant women and they just measured their normal heart rate, blood pressure, respiratory rate during pregnancy. Sounds so simple, but believe you me, it had not been done until this study was published. Everyone just, well, I know the heart rate goes up a bit, the blood pressure goes down a bit. They actually measured it, they actually worked it out. And the cutoff that we used to use for heart rate in pregnancy was 100 until this study. We now know that normal pregnant women, 95% of them, to be precise, will have a heart rate that goes up to 110 just because they're pregnant. They're not septic, they haven't got a PE, they're just pregnant. That's not to say you should ignore tachycardia, but you need to know what tachycardia actually is in pregnancy. So we are used to looking at the relative tachycardia and also the relative hypotension of pregnancy. These are what happens to the lung function in pregnancy, and women are often breathless in pregnancy, as you will know. The reason they are breathless is because their increased minute ventilation increases. They breathe more deeply, but they do not breathe more quickly. That means that you can take a respiratory rate that's abnormal as truly abnormal. If a pregnant woman is breathing fast, there's usually something wrong with her. But her PO2 will be higher, and her PCO2 will be lower because her minute ventilation has increased. Similarly, as the diaphragm is pushed up by the gravid uterus, her FRV will be reduced. And all of these things, you have to put those into the melting pot of working out if she's breathless, is this an acute medical problem or not? So I mentioned serum creatinine earlier on, and this is work from Michelle Helanovic in Canada, who did another very simple study. She just measured serum creatinine throughout pregnancy. So the first thing to note is you cannot use EGFR in pregnancy. It's not validated. So for the nephrologists among you, forget EGFR, doesn't work. You have to use serum creatinine. And then you have to understand that because of the increased renal blood flow, the creatinine falls as part of normal pregnancy. So when you have a woman with preeclampsia and her creatinine is 80, that is abnormal. That is abnormal, assuming she didn't have CKD before she was pregnant, which you won't know unless you measure the serum creatinine at baseline in all your hypertensives, all your women with diabetes, which we try and do in the UK, but often we don't. And of course, she might present with preeclampsia, having not had pre-existing hypertension, so you won't have a baseline creatinine to use as a reference. There are anatomical changes. And for example, there's physiological hydronephrosis, worse on the right than on the left, and we're used to ignoring the ultrasound that says bilateral hydronephrosis, because we know that's just part of normal pregnancy. But similarly, I've shown that the pulmonary embolism is the leading cause of death. So everybody is worried that the woman presenting in front of you with chest pain or breathlessness has a pulmonary embolism or a DVT. And to diagnose DVT, we use ultrasound. But swelling in pregnancy is very, very common. It's also asymmetric swelling is also common. Why? Because outside pregnancy, the right internal iliac artery overlies the left common iliac vein. If you transpose on that a gravid uterus, it is normal to have more obstruction to flow on the left than on the right, and that is the explanation for why DVTs are 9 times more common on the left leg than on the right leg in pregnancy. It doesn't mean to say it can't be a DVT if the swelling is on her right leg. But these are anatomical changes that you need to be aware of. So on pulmonary embolism, which I'm just going to spend a little while on, the well-read among you will say, well, look, we worry about PE, but that's okay. We have D-dimers, we have VQ scanning, we have CT scans, we can use clinical decision rules just like we do in the ED, we can use a Geneva score, we can use D-dimers, and we can exclude PE without imaging the woman. I'm very sorry, but you can't. And the first reason you can't is that D-dimer increases in pregnancy. And it doesn't increase magically from one cutoff in the first trimester to another in the second to another in the third. It increases gradually. So if you're going to use D-dimer, what cutoff are you going to use at 25 weeks? That you can't use a cutoff. And we don't use D-dimers, or I teach all my registrars not to use D-dimers. There is a move to use D-dimers in clinical decision rules, and I'm going to show you why I don't think that's the right thing to do in a minute. But chest x-ray, often left out in pregnancy, that's the first problem, but once you've understood it's the same amount of radiation as flying to Trinidad and back, which you don't stop pregnant women doing, you will do a chest x-ray, but you need to understand what happens to that chest x-ray as the woman becomes more pregnant. This is the same woman who happened to have 3 chest x-rays in pregnancy. This was early on in her pregnancy, this was as it progressed, and this was in the 3rd trimester. That's the same woman. Now, if you just did the chest x-ray in the 3rd trimester, you will often hear people trying to report that as saying, oh, the heart looks enlarged because it's pushed up. Then the breasts have enlarged so the plate isn't so close, so the beam diverts more and that makes the heart look bigger. Similarly with ECGs, this woman had a series of ECGs done in pregnancy. This is her ECG done at 28 weeks, nice and normal, hope you agree. This is her ECG done at 33 weeks, same woman. S1Q3T3, right? She's got a PE, right? No, wrong. These are all physiological changes of pregnancy, and we are used to ignoring them. It stays like that, 34 weeks, and then this is the same woman, ECG 2 days postpartum. So you need to understand what happens to the ECG, the chest X-ray, and all the blood tests before you can interpret the problem in front of you. So this is a document produced by some acute medicine, obstetric medicine colleagues of mine, and it's to help you recognize those remember Ciara spoke about the red flags. So this is just a table showing the differential diagnosis of breathlessness in pregnancy, and it's like a helpful aide-memoire to physicians. So when faced with an acute medical problem in pregnancy, I refer you to this document, which is freely available online on the RCP website. But it leaves out important things like acidosis is a common cause of breathlessness, and DKA is sadly a not uncommon cause of death. And pulmonary edema is not on this list, which is probably, I always say to trainees, to obstetricians, if you can diagnose pulmonary edema, you will save lives. It's that simple. But yet, every woman who comes in breathless is assumed to have a pulmonary embolism, and they don't think about pulmonary edema. This is the data I showed you already, but with the numbers blown up so that you can see how important pulmonary embolism now is. So having just told you that not everything is a pulmonary embolism, I'm now showing you a picture saying it's the most important cause of death. And herein lies the problem. Everyone is worried and wants to diagnose a pulmonary embolism. Or more importantly, you don't want to miss it in a pregnant woman who presents with chest pain or breathlessness. It's a bit of a needle in a haystack. So I thought it would be useful to share this case. And I'm not afraid to hang up our dirty laundry in public, which is what I'm doing. Because you might think, oh, the UK's got half the maternal mortality rate, we have obstetric physicians, everything's fine and dandy. It is not. This is a real case from my own hospital. A 36-year-old woman who was 36 weeks pregnant, no relevant past medical history. She, in fact, became breathless during the cesarean section. And the anaesthetist and the obstetrician noticed that, and she also complained of chest heaviness. So they were worried that she had a few risk factors. This was an emergency cesarean section. Could this be a PE occurring during a cesarean section? She was not tachycardic, her blood pressure was normal. Note the respiratory rate, which was elevated. Her JVP, by the way, this is my examination, not what they did at the time. Her JVP was raised, she had bibasal crepitations, she was hypoxic. Her ECG showed normal sinus rhythm. And because they were worried that she had a PE, she didn't have a chest X-ray, she didn't have a proper examination done, what do you think she had done? She had a CTPA done because they were worried about a PE. Her BNP was normal, her troponin was mildly raised. And I was asked to review her with my team the next morning. And I asked her one question. I said, well, she was lying flat on her back on 2 liters of oxygen. I said, are you breathless lying flat? She said, yes. So I sat her up and she said, thank you. Now that's not disrespectful to obstetricians, it's not disrespectful to anaesthetists, it's not disrespectful to midwives, it's real life. And it's what happens when, if you do what Ciara told you not to do, and you don't want to exclude a diagnosis, you want to make a diagnosis. So this is the CTPA that this woman had done. These are the pictures, these are screenshots of the pictures. This is obviously not normal. And this is where it gets really bad and really embarrassing, but I'm not embarrassed to share it with you. This was the CTPA report. So it's done to exclude a PE, and it says there is bibasal predominant bronchiectasis. It says there's no suspicious of pulmonary embolism, no pulmonary embolism. Next line, thoracic findings are consistent with pulmonary edema. This report was available in the notes on the computer, we're all digital, 3, 4, 5, 6 hours before I did my ward round. She was still on oxygen, she hadn't been sat up, she hadn't been given furosemide, she hadn't had a positive diagnosis made. Actually, you could make the diagnosis from just looking at the fluid chart, and forgive me, Dean, she had had 3 liters of fluid intraoperatively because what I didn't tell you is she'd had a postpartum hemorrhage. They'd filled her with fluid, she'd gone into pulmonary edema, and they'd assumed it was a PE. And and then everyone wants to do an echo, right? Because she's in pulmonary edema. No, she doesn't need an echo. She hasn't got heart failure. She's got pulmonary edema, which is completely iatrogenic. And you don't waste money doing an echo, which I understand is not that easy to get here anyway. You just need to do a chest x-ray, take a history, take an examination, do the chest x-ray, which shows pulmonary edema. So we see a lot of pulmonary edema, and as you've just heard, cardiac disease is the commonest cause of death after COVID and pulmonary embolism. And people always think, oh, yes, she's pregnant. I've heard of this thing. It's called peripartum cardiomyopathy. I can't think of the last time I saw a case of peripartum cardiomyopathy. It was probably 5 years ago. Most of the cardiomyopathy we see is actually previously undiagnosed, unrecognized dilated cardiomyopathy rather than truly peripartum. But most of the pulmonary edema I see isn't cardiomyopathy at all, it's preeclampsia or iatrogenic fluid overload. And when women have preeclampsia, they are more prone to pulmonary edema because their capillaries are leaky, their albumin falls, and they're very prone to pulmonary edema. In the days when we used tocolysis with salbutamol, that gave women pulmonary edema, and non-steroidals given postpartum can cause pulmonary edema. Yes, she might have underlying cardiac disease, and that's important to recognize. And if you suspect that, she needs an echo. Or she might have new cardiac ischemia. But the key here is that physicians know that not all that wheezes is asthma, because they were all medical registrars. They've all seen pulmonary edema presenting as wheezing. But to obstetricians, wheezing means asthma. And giving a breathless woman in pulmonary edema IV fluids and IV salbutamol is not a very good treatment for pulmonary edema. So I've already said that pulmonary edema and preeclampsia is important, and learning about preeclampsia and the medical consequences of it, eclampsia, HELP syndrome, pulmonary edema, cortical blindness, is a big part of what obstetric physicians do, because these are all rare things, but we see them a lot because we get involved in the more severe cases of preeclampsia. So I'm going to just show you some examples of why you must never ever leave out the chest x-ray. And these are all cases of real chest x-rays in real pregnant women where the chest x-ray was either not done or delayed. And this is a case of one with asthma who was breathless, treated for asthma, not getting better. So the collapsed left lower lobe and the left lower lobe pneumonia was missed. And she wasn't given antibiotics until this was done. This is a case where the woman was 1 day postpartum, and she described feeling suddenly getting chest pain and feeling breathless during the second stage of labor. And sudden breathlessness, again, what did they think? Pulmonary embolism. And my registrar at the time was told that this chest x-ray was normal. And for those of you that can see well, you can see, I haven't got a pointer, but Ciara will stand up and point to the surgical emphysema and the pneuma mediastinum that you need. So this woman didn't need a CTPA. She just needed a careful history. I suddenly got breathless as I was pushing my baby out. A careful examination, the surgical emphysema, which was missed, and then a chest x-ray. She didn't need a CTPA. Not all chest pain and breathlessness is a pulmonary embolism. So I'm going to talk about cancer. Why I'm not a gynae oncologist. Why on earth am I talking about cancer? Because women are older. And therefore, we see cancer much more often than we used to in pregnancy. And this, again, this is Melanie's slide, but you can see that in the pie chart on the bottom left, cancer is one of the commonest causes of maternal death when you take the 6 weeks to 1 year postpartum. But it's often the opportunity to diagnose it that has been missed in pregnancy because of failure to investigate weight loss, failure to examine or find lymphadenopathy. And the commonest cancers we see are breast cancer and gastrointestinal cancer. And these purple boxes are what are called vignettes. They're taken directly from the Embrace Inquiry. And I'll let you just read this story. This woman was older, she was 13 weeks pregnant, and she gave a 3-month history of a breast lump. She was rapidly referred, and the cancer was diagnosed. But they thought it was early cancer. They didn't perform any staging investigations, so she was treated with surgery. She didn't have a chest x-ray or a CT of her chest. She underwent wide local excision, an axillary node clearance, and the axillary nodes were clear, and she was started on chemotherapy. So as a sideline, You might not think that cyclophosphamide is safe in pregnancy, but we use cyclophosphamide in the second and third trimester to treat breast cancer probably 2 or 3 times a year, which is how many breast cancer cases we see. So she had FEC, standard chemotherapy, for her breast cancer. But then in the third trimester, she developed chest pain. And because she was third trimester of pregnancy and she had chest pain, she underwent a CTPA to exclude a pulmonary embolism. And that investigation sadly showed that she had spinal mets. And her baby was noted to be small, so she underwent an elective section earlier. Normally you'd wait till term 38, 39 weeks to deliver a woman with breast cancer. She had a GA. Her baby developed respiratory distress and required neonatal intensive care. So the issue here is that she had metastatic disease, but they didn't diagnose it because they didn't stage her. They didn't stage her because they didn't know that you can do MRIs in pregnancy, you can CT scan the head, the chest. I mean, I don't understand why people are so ready to do a CTPA to exclude PE and yet so unwilling to do a CT to exclude chest mets in pregnancy. Why? Because the person making this decision is an oncologist, not an acute physician. So the oncologist assumes that you can't do a CT scan in pregnancy. And so when women present with cancer, which they do, the role of the obstetric physician and the obstetrician is very much to say to them, have you staged her? Have you excluded metastases? Because that's going to influence what sort of chemotherapy, what sort of treatment you give for her cancer. I'm now going to spend a bit of time talking about medication in pregnancy. I said that was an important part of our role. And these points are made by the EULAR, which is the European League Against Rheumatism. So they were written by rheumatologists, and they've actually just been updated, but the updated version isn't published, so I can't share it with you. But you need to talk about medications before the woman gets pregnant, and you need to talk about contraception before the woman gets pregnant. I don't want to tread on Sonji's toes because she's going to talk to you about contraception, but I think that doctors who become physicians, or rather avoid obstetrics and gynecology, is because they don't want to talk about sex and periods and contraception, because it's very distasteful and a little bit embarrassing. So I'll do medicine, then I won't have to deal with all that gynae stuff. And although it's a joke, it's actually real, it actually happens. Contraception is not discussed in transition clinics. Women become of reproductive age with chronic medical conditions with no counselling about contraception, and then they get pregnant in an unplanned way, which is not what we want. So women with chronic disease need pre-pregnancy counselling, and obstetric physicians can provide that, together with the specialist physicians who are used to looking after them in pregnancy. When you're worried about whether a drug is safe in pregnancy or not, what you have to think about is not just the safety of the fetus, but the safety of the mother. The default option must not and should not be, she's pregnant, I'm going to withdraw that drug. She's pregnant, I can't use that drug. Because if you withdraw it, and you're dealing with rheumatological conditions or inflammatory bowel disease, you risk a flare of that disease. That will lead to prematurity, which is far more dangerous to the baby than any drug that we would use to treat it, provided you check with the obstetrician, you check with the obstetric physician, is this drug compatible with pregnancy? It's never, never wrong to ask. What is wrong is not to ask and assume the drug's dangerous, or rely on I don't know what you use in Trinidad, whether you use the British National Formulary or the US Desktop Guide, but whatever you use, I can guarantee it will be wrong with regard to drugs in pregnancy, because it will just say, advisors avoid. Drug company advisors avoid, and that's interpreted as, oh dear, I can't use it. Only 5 drugs have a license for use in pregnancy. Can you imagine we wouldn't be able to treat anything if we could only use these 5 drugs? So you must balance the risk of drug therapy to the fetus, which is normally theoretical and often unknown, versus the risk of not using that drug to the mother, and therefore her fetus. And that decision must involve the woman. We shouldn't be telling women to stop or start drugs. We should be involving her in that decision about whether she wants to continue that drug when she's presented with the data, as best as we have them, about that drug in pregnancy and breastfeeding. So this is another infographic taken from Embrace about forward planning. And again, Sonji will mention this with regard to contraception. But this is, if you like, the reproductive cycle. The best opportunity to catch women for pre-pregnancy counselling is when they've just had their baby, because you have no guarantee that you're ever going to see her again before she presents pregnant again. So take the opportunity to engage her in care post-pregnancy about her next pregnancy. So back to my solutions. We need to improve maternal medicine training for obstetricians, and Ingrid will talk about that. We need to improve obstetric medicine training for physicians and stop them, because this really annoys obstetricians, is neurologists and neurosurgeons who say, this woman with an AVM must have a cesarean section. They don't know anything about cesarean sections, and they have no idea about passive second stage and forceps and Ventouse and effective epidurals. They just think cesarean section is a zip, open it up, take the baby out, close the zip, all very nice and tidy, and their AVM isn't affected. That's what they think. I promise you neurosurgeons think like that. I hope there are no neurosurgeons in the room. We need to train more obstetric physicians. And this is the bit that I really want to come on to. So this is what's called the NHS long-term plan. It was written over 5 years ago, and this is why we now have obstetric physicians in the UK in bigger numbers. It's because the politics lined up with what I became a consultant in 1996, and I said to Michael de Sweet, don't worry, Michael, I'll sort out obstetric medicine training. I think it'll take me a couple of years. 28 years later, I have made some progress. But it did not happen in 2 years. It didn't happen in 20 years. It took political will and the right landscape for it to work. And we had a national clinical director for obstetrics, and he was very supportive, and he put me in touch with the civil servants, and we sat in a room with a flip chart, myself and an obstetrician, and he said, I don't understand, write it on the flip chart. I'm allergic to flip charts, I hate them, but for that, I did it, and I put it on the flip chart and explained what obstetric medicine was. And this was the Department of Health, and it said it would develop a network of maternal medicine specialists across the country to care for pregnant women with significant health conditions. Then we had a series of reports by failing, and not failing, that's a strong word, by maternity units that were in trouble that reached the press. And you will have read about these. This was the Shrewsbury and Telford inquiry, so-called Ockenden inquiry. And what Donna Ockenden said, because she had obstetric physicians on the panel, was that women with diabetes and hypertension must have access to pre-pregnancy counselling. Must have access. That's a very strong thing to recommend. And that you needed a sustainable training program across the country. So it wasn't just make obstetric physicians, it was make it sustainable. And the only way to make it sustainable is to have a training program. And this is where the Royal College of Physicians came in. They developed the diploma in obstetric medicine. This is what Ciara did. It's 12 months, and it's open to any physician who has a physician training number in the UK. And these, what we call SIPs, these capabilities in practice, this is what all physician trainees have to acquire in those 12 months. It's freely available on the website. But this is what has made the difference, because now physicians have a pathway. They have a legitimate training. They have a piece of paper. I don't have a piece of paper. I never did this. Many people who came after me don't have that, but Ciara has a piece of paper, and this allows her to practice as an obstetric physician. This slide again is courtesy of Melanie, because now I'm on a sales pitch to convert all the physician trainees in the audience to the obstetric physicians of Trinidad of the future. You get to be a generalist. You don't have to specialize. You get to understand the physiology of pregnancy. You understand that what happens in pregnancy tells you about that woman's subsequent health. You will know that that woman with preeclampsia is at risk of cardiovascular disease, cerebrovascular disease, hypertension. You have a patient within a patient. You get to look after two patients at the same time, and you get to look after women at the most important period of their life and see the joy on their face and hold their babies when they've been told, you're far too ill, you can't get pregnant. You act as a project manager, so you're a specialist on these rare things, but you're also a generalist, which old-fashioned doctors like me, that's why we went into medicine, to be a generalist. So this is what's happened. So in the 1980s, there was Michael de Sweet and another gentleman called Professor Chris Redman. There were two of them. Michael trained me, so in 1996, there were three of us. By the 2000s, Michael trained two other people, Professor Catherine Williamson, my colleague, and Professor David Williams, my colleague in a different hospital. And then we trained a few people, and by 2014, there were about 10 of us, mostly in London and in Oxford. In 2022, after the government came on board, after we had recognised training, after the country saw the value of obstetric medicine, we had about 20. And then this year, I counted them up. The only way I can count them is because we're all on one WhatsApp group. So I had to go to the WhatsApp group and count the names. And there are 34 of them who are now working. And but I'm defining obstetric physician as a consultant who is paid, who has paid sessions in obstetric medicine. They might do something else as well, but they have dedicated time to practice obstetric medicine. So 34 is not enough for the country, hence the importance of the training programme. Before the UK got there, Canada, Australia, New Zealand, and pockets of the USA got there years ahead of us. Now we have them in South Africa because I've trained someone who encouraged someone else in South Africa, India, and France. The picture on the left at the top was taken from our National Society in 2022. So all those physicians, most of those physicians are people that I trained and that were trained at the 4 hubs. And then the picture on the right is taken this year, actually last year, in Norwich, which was the inaugural meeting of the maternal medicine networks. So in that photograph, you see many of the same faces, but you also see the lead obstetricians and the lead midwives. And this brings me on to the networks. So the networks are partly about creating and maintaining obstetric physicians in each of the regions of the UK, but also, and this is so important, keeping the care where possible locally. This is not about finding women with medical disease and sending them all up to the teaching hospitals. It is about keeping the care local and improving the expertise in the local units with the help of a lead midwife and the help of a lead obstetrician from whom you'll hear later. And this is so important. Different women need different care. And you can't just say, this is the care, this is the pathway, this is what women get, this is what we're doing. Because those women that are hard to engage are the women who are at highest risk. So that's where we have to spend extra time and go the extra mile for them. It's about equity, not just equality. So this is a map of England. These are the regions. And the white bit in the middle is London. And Ciara works in southwest London. Myself, Sonji, and Sharon, who you'll hear from in a minute, work in southeast London. And southeast London has about the same population as Trinidad and Tobago, and that's just one of the 5 regions in the UK. And so this is, the networks each have a lead obstetric physician, like myself or Ciara, a lead obstetrician, and a lead midwife. And we work together to make sure that where possible we keep women's care local, but that she has access to the expertise that she needs to have her medical condition correctly managed. And to do that, we divide medical problems into A, B, C. We're very simple, right? A means she can be looked after locally. B means she gets advice from the centre, but can usually deliver locally. C means she's really high risk. She's got pulmonary hypertension, she's got a mechanical valve, she has to be looked after in the centre because of co-located services. And we provide system-wide education, we develop protocols and get them agreed, and we support the management of difficult cases. Now, I've left this slide till the end because it's probably the most important slide. Ciara, you're going to be my pointer again, okay? So the top line is total maternal mortality rate. The green line below it is what would happen. It's blue, it might be blue. It's the little bit that goes off. What would happen without COVID? And then the dotted line is indirect deaths, they're medical, and the dashed line is direct deaths. Now the green dots, Ciara, the green dots are what would happen to indirect deaths if we took COVID away. And can you see that that has now crossed direct deaths? So for the first time ever since I became a consultant, indirect deaths, medical deaths, are less than direct deaths. I am quite an arrogant person, and I'm not going to take credit for doing this, but I am going to say that that is the way you reduce deaths from indirect causes. You have physicians involved in their care, and I really hope the whole line. It's shocking that the death rate's gone up, but it gives me a little bit of solace that the percentage of indirect deaths is going down. I'm going to leave you with, do what you would do if the woman wasn't pregnant. Don't just leave stuff out. That's so important. And we heard about social determinants of disease. We've heard about how diseases are changing, pregnant populations are changing, and we're not going to make an impact in any country, in any healthcare system, unless you understand the social determinants of health. And as has already been said, we need social care, that we have women who can't pay to come up to the hub to get an opinion. We have women who can't pay to feed their children and to feed themselves, and we have malnourished women in pregnancy. And by improving the care of women, you improve the health of the next generation, which is really the only way we'll be able to assess whether what we're doing is correct or not, is whether the children of those women, whether we reduce their obesity rates, their hypertension rates, their diabetes rates. I'm sorry I've gone over time, and thank you very much for listening.